All right, engineers, in this video today, we're going to be talking about chronic leukemias, which includes chronic myeloid leukemia, also known as CML, as well as chronic lymphocytic leukemia, also known as CLL. Again, this is a part of our clinical medicine section. If you guys like these videos, they make sense to you, please support us. You can do it by hitting the like button, commenting down in the comment section, or subscribing. Also, go down in the description box below. In there, we'll have a link. It goes to our website. On our website, if you become a member, you can have access to notes, really good ones too. Illustrations to help you to follow along with me during this lecture, as well as quiz questions to really test your knowledge and have that spaced repetition. So go check it out. All right, let's get into the pathophys. All right, so let's discuss the pathophys here. When we talk about chronic leukemias, we have to have a basic understanding of hematopoiesis. Then we got to go through the different components of that because it's really critical and helps us to delineate the abnormalities or the aberrancies within the myeloid lineage and then the lymphoid lineage, which helps us determine if it's, in this case, CML or CLL. All right, so hematopoiesis, which are the cells that are affected in this pathway? It's all blood cells, right? So you're going to have, this is going to basically, hematopoiesis is the production of all blood cells, right? So this is going to be all your cells. So this is going to be the red blood cells, this will be your white blood cells, and this will be the platelets. These are the cells that are going to be primarily affected here. And when we talk about the white blood cells, obviously this can be broken down into the agranulocytic white blood cells, which are the lymphocytes, the natural killer cells, and then the monocytes, as well as the granulocytic white blood cells, which are your neutrophils, eosinophils, and the basophils. The next component here is where does hematopoiesis take place? So we know it's the production of all blood cells, but it takes place in the red bone marrow. And this is really important to remember, right? Obviously, this is the site of where you want to produce blood cells. Now, there is other areas where this can occur besides the red bone marrow. That's called extramedullary hematopoiesis. That's things like the spleen, the liver, but the spleen's the really big one, and that can actually cause the spleen to get bigger as a result. We'll talk about that a little bit later with CML. But this is the location. These are the cells that are affected. Obviously, so here we're going to take a bone. This is going to be the long bone, the femur. The femur will have a red bone marrow, and it'll utilize that to have these stem cells, which are going to be making all of these different types of blood cells, right? Making our white blood cells, making our red cells, making our platelets. The question comes is, how does one cell help to make all of these? Well, it's a pluripotent stem cell, right? So we're going to have an initial pluripotent stem cell, which is going to help us to make all of these cells that we so desire. And this is called a hemocytoblast. Now, hemocytoblast can differentiate into two different cell lines. One is going to be the myeloid cell line. So this is our myeloid stem cell. But then it can also make a lymphoid stem cell. Now, obviously, if there's abnormalities that are going to occur in the myeloid lineage, that's what leads to our chronic myeloid leukemia, or CML. If there's abnormalities within the lymphoid lineage, that's what leads to our CLL, our chronic lymphocytic leukemia. Now, it's important to remember that the myeloid stem cell, it can help to make a bunch of different cells. One of them is eventually it'll be utilized, it can convert into what's called an erythroblast, and then it'll make your red cells, so we can make red blood cells. It can convert into a megakaryoblast, and then into a megakaryocyte, and then break open into platelets. It can also convert into a monoblast, and the monoblast eventually will turn into a monocyte. So from here, we can get a couple different types of cells. One is you can get a monocyte, which is a type of agranulocytic white blood cell. You can get platelets, and you can get red blood cells or erythrocytes. So we can see now from that myeloid stem cell, there's a lot of different cells that are made, but that's not the ones that we're really caring about. What we really care about is if we come down from the myeloid stem cell, it turns into a blast, a special one to make these granulocytic ones, right? So we said erythroblast, megakaryoblast, monoblast. This one is a myeloblast. Myeloblast. Now, if you remember, when we were talking about AML was acute myeloid leukemia. There was an abnormality in the myeloblast where what happened? Could have been translocations. 1517 was an example of them. Could have been chemoradiation. Could have been a lot of different things. But we shut down the ability of the myeloblast to make any of these mature cells. And then it just kept proliferating and make a lot of those. We're in the chronic stages. So chronic doesn't affect the upper blast stage. It affects further down this lineage. So that's where we're going to have to look. So now we're going to take this myeloblast and we're going to convert it into another one. This one is called a promyelocyte. Now, all right, this should sound somewhat familiar. Oh, that was the one where if we had a lot of this guy, the promyelocyte, he could make APL. That could lead to APL. All right, so we're not at that point yet. Let's go to the next stage. The next stage is a myelocyte. A myelocyte. And then from a myelocyte, it can then actually go a little bit further, and it can turn into what's called a metamyelocyte. And then from here, because the nucleus, look at the nucleus, is changing. It's a really large nucleus, starts becoming somewhat segmented, more segmented. You start getting multilobulated nuclei, and then finally you get the final structure here. At this point, we call it a band cell, which is the one cell right before we get to the final granulocytic stage. Now here, I'm gonna have my most abundant one, which is my neutrophil. Then here I'll have my eosinophil. And then here I'll have my basophil. Here's what I want you to remember. Promyelocyte can convert into a myelocyte. Myelocyte to a metamyelocyte. Metamyelocyte to a band cell. A band cell to the special granulocytic white blood cells. All right? Now, here's what we're noticing. In AML, it was right here or right here where we stopped. In CML, it actually doesn't affect these cell lines. It affects further down. So these things can proliferate, and what actually ends up happening is you can get lots of myelocytes, you can get lots of metamyelocytes, you can get lots of band cells, and you can get lots of neutrophils, eosinophils, and basophils. You're not going to be affecting the myeloblasts and the promyelocytes. We're getting into the later stages where they're a little bit more like mature appearing. That's the big difference. So when we talk about chronic myeloid leukemia, this is ones where you're getting lots of granulocytes. So we're going to call these granulocytes. But here's the key, important terminology. It's granulocytes at various stages. So if I were to take a patient who had CML, I take their blood. When I take their blood, I'll get a CBC, it'll show a really high white count. I'll look under the microscope and I'll look and I'll see these different cells at various different stages in their actual cycle. That is the key. So you have to remember, it's at various stages. That is really, really important to remember. So when I get a blood smear on a patient who has CML, they'll have a high white cell count, and it'll be lots of the granulocytes. But when I look at the blood smear, they could be myelocytes, metamyelocytes, band cells, or any of these. That's the key thing. Now, one more thing with CML. CML, when you get a patient and you get a CBC and you see a white count that's near close to 100,000, that might make you poop your Huggies a little bit, right? You get a little scared. You're like, oh boy, I don't know what's going on here. There is an important distinction for your boards. One is you see a white count. So if I see a patient who has a white count that's really high, I need to know, is it CML, malignancy, or a leukemoid reaction? Let's define this. What is a leukemoid reaction? A leukemoid reaction is when a patient has a reactive process. Their bone marrow is making lots of white blood cells because something is telling it to. Usually an infection, like sepsis, or inflammation, autoimmune diseases. It could be from surgery, stress. Lots of different things can happen here. But it's a reactive process. So what happens in this is the white cell count goes up, but not to the point of a malignancy. So when I look and I have to differentiate this, where I get a white cell count that's elevated, and I want to know which one it's likely, when the white cell count is teetering near the point or greater than 100,000, that suggests more likely CML. When the white blood cell count is less than 50,000, that's less likely, in this case, a malignancy, and more likely a reactive process, like a leukemoid reaction. Another thing, when you look at these cells, so first thing you'll notice, okay, white count's really high. If the white count's high, it could be all mature, like appearing. You're gonna get lots of neutrophils, eosinophils, basophils, you may get some band cells, some metamyelocytes, some myelocytes. When you look at their differential, so you get a CBC with differential, it'll tell you all of these different things. And that's what's really important. We look at something called a left shift. All that means is, this is gonna be, let's say, the middle line, all right? This is your base. Anything upstream at these stages up here is a left shift. The more you have of these, besides your neutrophils, eosinophils, and band cells, is a left shift. That is a really important thing to remember. If I have CML, would I have a significant left shift? Yeah, I'm gonna have lots of myelocytes, metamyelocytes, band cells, and all of these. That's really important. So when I look at the left shift here, it'll be through the roof. Where here, you may get a little bit of a bandemia, a little bit of some band cells, a little bit of metamyelocytes, but you're not going to have as many of these myelocytes. That's a really important term that we have to talk about. So you may get one arrow. So now here's what's really important. With CML, they exhibit something on their differential, which is actually critical to know. This is called a myelocyte bulge. And you're like, bulge? Bro, what you talking about? I swear this is a terminology. All this means is, when you look at their left shift, their differential, their cell lines, in this scenario, it may have a little bit more of the myelocyte lineage than they do the metamyelocytes. Whereas when you look at a leukemoid reaction, they may have more of the metamyelocytes or the band cells. That's the big difference. So when you look at that, you'll see a higher myelocyte count. That's going to also be suggestive of CML. There's another thing for CML that's also really important. Another thing here is, with CML, when you have these white counts that are really, really high, it's really important to remember that CML affects all of these granulocytes. Usually in a leukemoid reaction, like an infection, inflammation, what's the most abundant cell that's produced? Neutrophils. You don't usually have basophilia. That's pretty rare. In CML, they have basophilia. That is the important thing to remember. I think this actually should be 1L. So basophilia. Now, if I have basophilia, I have a myelocyte bulge, and I have a white count that's greater than 100,000, makes me think about CML. Let's put the nail in the coffin. The nail in the coffin here would be a LAP score. A LAP score is basically whenever a neutrophil is in a scenario of infection, inflammation, it releases leukocyte alkaline phosphatase. So if you are in a scenario of elevated inflammation or infection or stress, the LAP levels would be high. So what do you expect for the LAP levels with the leukemoid reaction? They're going to be high. That's the important thing to remember. So you'll have an elevated LAP score here for the leukemoid reaction. What would you have here for a malignancy? You don't have these neutrophils that are actually going to be at the stage where they're releasing lots of the leukocyte alkaline phosphatase. So their LAP scores tend to be low. That's the big difference here. So they'll have low LAP scores. And so that's the last thing that I want you guys to remember, is that for CML, they'll have very, very low LAP levels. And that, my friends, is the biggest way for whenever they come up on the exam to try to test you about differentiating CML from leukemoid reaction. It'll basically be a patient who comes in, they get a CBC, and they have an elevated white count. And you need to figure out, is it this or this? Look at the white count, look at the differential, look at the left shift. If you have more of that myelocyte bulge, CML. And then lastly, look at the LAP levels. If the LAP levels are low, it's more likely CML. If they're high, more likely a reactive process. Okay, that's for the CML aspect. So from this point, CML is an increased number of granulocytes at various different stages. More likely in the myelocyte range, you're going to see a lot of these. Big reason for this, again, is going to be a genetic problem, which we'll talk about. There's some type of translocation, a chromosomal translocation, that's causing these cells to proliferate rapidly, making lots of these cell lines. And they do differentiate. They're more mature appearing, but they're not going to be functional. And that's where this disease can be problematic. Now, we go to the lymphoid lineage. And the lymphoid lineage, it's a little bit different. Let's talk about that. So for the lymphoid lineage, you have to remember what happens to this lymphoid stem cell. It gets turned into a lymphoblast. Now, if we're really being particular, these lymphoblasts can turn into what's called prolymphocytes. Here, we'll put that down. Here, we'll actually have one more. We'll say here I have a prolymphocyte. And then from the prolymphocyte, we finally turn these puppies into a T lymphocyte. I'm just going to write T cell though, or a B lymphocyte or a B cell. And then we know here the B cells can become plasma cells, right? But we're going to stop it right here. So lymphoid stem cell to a lymphoblast, lymphoblast to a prolymphocyte, and then from here to a T cell or a B cell. In chronic lymphocytic leukemia, the abnormality does not exist here at the lymphoblast. It's not really here at the prolymphocyte, it's here. When you actually check a patient's CBC, you'll see they'll have a very high white count. But it's not going to be the granulocytes, the eosinophils, neutrophils, basophils. Those aren't accounting for this really high white count. What are you going to see? A lymphocytosis. So with CLL, you're going to have more of these B cells and these T cells. So you're going to have an increase in your lymphocyte count. So lymphocytes. And these are going to look mature. These are mature appearing, dude. So that is really, really important to remember. When I look at ALL, they could have a high white count, but when I look at the blood smear and I look at the overall morphology, for ALL, there'll be lymphoblasts. For CLL, there'll be mature appearing B cells or T cells, but they're not going to be as functional. Now, one more thing. For granulocytes, we don't have a set number of like, okay, that's a really important determination that this is a elevated white cell count, particularly affecting the granulocytes. We stick to that a lot with the CLL. So we actually need to know how many of these lymphocytes are really high to make us consider a lymphocytosis as the source of the CLL. And it's an important number to remember. So this number here is we actually need to have this number be greater than 5,000. So when you look at it, you want to have greater than 5,000 of these lymphocytes per microliter of blood. So when you get their absolute lymphocyte count, it needs to be greater than 5,000 lymphocytes per microliter of blood to be a true lymphocytosis. And that is accounting for their high white count. What's the most abundant white blood cell? Neutrophils. What's the second one? Lymphocytes. Right? So you always remember never let monkeys eat bananas or nobody likes my extra boob, right? So never is neutrophils, L is the lymphocyte. That is the second most abundant. So if this one's really high, it can impact your white cell count. So this is going up, increase the white cell count. These going up increases your white cell count. All right, we're on to something. Now, it was important to differentiate CML from a leukemoid reaction. It's actually really important to differentiate a normal cell, a normal lymphocyte, from a CLL cell. What do I mean? Okay, when I take a cell, a lymphocyte, and I look at this cell under special studies called flow cytometry, it's important for me to know the specific cluster differentiation proteins that are present, because that distinguishes me from a normal or a lymphoma cell from a CLL related cell. It's super important. So I got you guys got to know this. For a normal cell, we have these proteins. Do you see these? These are called cluster differentiation proteins. And normal ones will have CD19 or they'll have CD20. You should have these. These should be present. So you should have these two present. Then we'll go to a mantle cell. This is a type of lymphoma. We'll talk about it in the lymphoma lecture. But this one will have the same thing. But we're going to add one more. It will have CD5, CD19, CD20. Most people will say, oh, if you got CD5, you're good. That's CLL. Not necessarily. Because CLL will have CD5, but so will mantle cell. So what really differentiates these? We need one more. You need to have CD5, CD19, CD20, one more, CD23. So when I look at these, what's the true difference in these structures? This one has CD19 and 20, which are these blue proteins. That one still has it, but these see these like pink proteins? That's the CD5. This one, it's got the pink, it's got the blue, it's got the orange, the CD23. When you do the flow cytometry, this will tell you, oh, this is CLL. It's not normal or it's not mantle, it's CLL because of this. You have a patient with a high white count, lymphocytosis predominant. You get the flow cytometry, tells you have these, done. You know, we don't even need a bone marrow biopsy. We don't need a bone marrow biopsy to diagnose CLL. We can do it right from the blood. Because if I have these markers of the peripheral flow cytometry, diagnosis done. That's why it's important to know this. Okay, at this point, we've utilized the hematopoiesis pathway to delineate CML from CLL. What delineates acute from chronic? We already talked about this a little bit, but we have a cell here. I'm using the myeloid because it's easier. We start off with a blast. Blast turns into a, what is it? Promyelocyte. Then into a myelocyte. Then into a metamyelocyte. Then into a band cell. Then into a, we'll use neutrophils. So in order for me to truly delineate where this kind of like lineage affects acute versus chronic, it's really right here. The blast and promyelocytes affect the acute. The myelocytes all the way down to the complete neutrophil, eosinophil, or basophil is going to affect the chronic. That's the big difference here. One more thing. With acute, again, these ones, rapid proliferation, but they don't differentiate. This one, rapid proliferation, but they do differentiate. This one is going to occur rapidly. So this is a rapid progression. This one is more gradual progression. This one is going to have more of an elevation of blasts, predominantly blasts. This one is going to have the more mature appearing cells. One of the really important things to remember, though, is that in both of these scenarios, if you got lots of blasts or you have lots of these mature appearing cells, doesn't matter. You can have a lot of these, not functional. A lot of these, not functional. So even though they may look like they're mature neutrophils, they may not function like mature neutrophils. That's important to remember. All right, so now we're gonna move into the causes. So we have to have ourselves kind of like really reasoning into this and thinking about why is it that I'm getting a lot of these mature appearing, but less functional granulocytes? What's kind of causing that process to occur? So for chronic myeloid leukemia, there's a lot of different things, but the most important one that you're gonna be looking for is a chromosomal translocation. So it's between 922. So if a patient has a 922 translocation, what they're doing is they're swapping some of the genetic material. So there's an ABL1 gene, and it gets moved over to the BCR gene on 22. So you're going to take this ABL1 gene, and you're going to transfer that puppy right over here into this red one, which is the BCR gene. All right. Then when that happens, you get this fusion. You get this like Frankenstein protein here. And this Frankenstein protein is the BCR-ABL1 gene fusion. All right. So this is the BCR-ABL1 gene fusion. Now, funny enough, this chromosome now on 22 is called the Philadelphia chromosome. Go Eagles, right? I guess. But this is the Philadelphia chromosome. So we're going to call this Philadelphia positive, just for right now. So it's the Philadelphia positive chromosome. And what it's going to do is it's going to help us to make lots of these unfortunate BCR-1-ABL gene fusion molecules. Once that happens, we get that gene fusion, it'll pump out the BCR-ABL1 proteins. So when you pump these things out, that's where you kind of get these issues. So now imagine here, I'm going to represent this protein with this like baby blue color here. So now we're going to get a lot of these proteins here. I'm going to give you a little Pac-Man. Here's your BCR-ABL1 protein. This is kind of like a tyrosine kinase, imagine. Right? So this gene down here is actually going to make these proteins, but we're going to just pretend it's coming from this side to help us with this. What it does is it'll bind on to this kind of like structure here. And this is a tyrosine kinase receptor. So this is going to bind on to this tyrosine kinase receptor. When it does that, basically what happens is it activates that tyrosine kinase receptor. And this is now, when it's auto-activated, this is going to essentially stimulate this receptor. It's going to auto-activate that receptor. When this receptor becomes activated, it'll send these intracellular signals down to the nucleus. That nucleus will then say, oh, I got some signals to start undergoing lots of proliferation and to inhibit my cell from dying. So this will then do what? This will stimulate an increase in proliferation and a shutdown in the apoptosis. So lots of proliferation. So you're going to undergo lots of that replication process, transcription, translation, and then you're going to decrease the apoptosis. The whole point of that is if I don't die, I can just continue to keep surviving. Do you see why this is kind of dangerous for these cells? You can make a bunch of them and they're like immortal. These are like little immortal cells running around. That's where this is dangerous. So the big thing to remember for chronic myeloid leukemia is watch out for the Philadelphia chromosome. You want to do cytogenetic studies. To do karyotyping, you'll find this abnormal Philadelphia chromosome, and you'll have to do further PCR testing to look for this BCR-ABL1 gene. And all that tells me is I got this weird BCR-ABL protein binding to the tyrosine kinase receptor, increasing the intracellular signaling and causing the cell to proliferate. The reason why I'm telling you this is when we give drugs later, we'll talk about these. I'm not going to talk about them now, but you can give a drug called a tyrosine kinase inhibitor. Guess what it's going to do? It's going to block the BCR-ABL1. You can't activate this receptor. You can't send the signals down. You don't proliferate and you die. That's the concept of why that's important to know this pathway, because we can use drugs to target that protein. All right. CLL is another one. Now CLL, there's not a lot that we really know about this. We think there could be something weird. So you have on your cell a BC receptor. So this is called a B cell receptor. And then there's a kinase here. And this kinase, we'll do it here. We'll do the same thing. This is going to be the little Pac-Man guy here. This is called a Bruton tyrosine kinase. So what is this guy called? This is called a Bruton tyrosine kinase. I'm going to put BTK. So the Bruton tyrosine kinase is a special structure connected to the B cell receptor that sends signals down to the nucleus for particular things such as proliferation and apoptosis, etc. Now, in CLL, there's believed to be a couple different reasons. We don't know exactly how, but the concept here is that maybe there is an abnormality of the Bruton tyrosine kinase. So the Bruton tyrosine kinase. Exactly how? Well, we don't really know. What we do know about CLL is that this is a disease of older individuals, usually greater than 70 years of age. Now, one other thing to remember is that, yes, there could be an abnormality in this Bruton tyrosine kinase, and if this thing is like undesirably activated, let's say, it'll help to activate this receptor and send signals down to the nucleus. And that nucleus will then say, hey, let me proliferate, trigger the proliferation, and let me inhibit apoptosis. Do you see why that's important? There's one other thing that may be playing into this, and it's really important for prognostic aspects here. Whenever you have a B cell, right, let's say here I have a B cell. The B cell is supposed to help me to make plasma cells, and then plasma cells undergo this process where they can make different types of antibodies, right? So they can make antibodies where they differ or they vary within their variable region of the antibody. So a normal process is you should have a B cell turn into a plasma cell, and a plasma cell should be able to vary their antibodies. That's normal. And we'll signify this by having, let's say here I have a little red structure here, and let's say here I have a little blue structure here. So they're supposed to be variable, right? So this is actually important because it's controlled by what's called the immunoglobulin heavy chain variant, all right? So there's a gene here that you actually need to know. It's called the immunoglobulin heavy chain, immunoglobulin heavy chain variant, the variable region on that. So it's what determines the varying component of the heavy chain. If I have a mutation in this, that tells me that the B cell is mature. It's been exposed to prior antigens. It's not naive, and it's therefore capable of actually acting mature and producing the respective antibodies. If I do not, so if there is no immunoglobulin heavy chain mutation, this is where it's like paradoxical in when you think about it. But if you do not have this mutation, what this tells me is that this B cell has never actually received the proper exposure, all right, and signals to help it to make these antibodies. So we're going to pretend it's now naive. If this is a naive B cell, it makes a naive plasma cell. A naive plasma cell will then produce what? It'll produce these kind of antibodies without the variants. And that is kind of concerning because it tells me that I have these immature, not functional, immature B cells. That's what's important. And so not having the mutation, what this tells me is it tells me this is a poor prognostic indicator. So this is a high risk, if you will, CLL. The reason why I'm telling you this is if a patient does not have this mutation, what it will do is it'll then make the B cell receptor pretty much sensitive to anything. If the B cell receptor is sensitive to anything, that means anything can hit this thing. That means you can stimulate this receptor undesirably. It'll then send these signals via the Bruton tyrosine kinase and cause increased proliferation and inhibition of apoptosis. So this is one of the things that you always want to check for when you have a patient who's diagnosed with CLL. You want to know, are they a high risk? And the reason why is if they're high risk, they'll respond really well to drugs that target the Bruton tyrosine kinase called BTK inhibitors. There is other genes that could be mutated here. It's always important to check for what's called the TP53 gene. And if that's mutated, that also suggests a high risk for CLL. I don't want to go too big down that. What I want you guys to understand is that there's some contribution here to the BTK enzyme. So if I have a patient with CLL, what would be a drug that I could target for that? BTK inhibitors. For CML, what's the big protein or enzyme? The BCR-ABL1, which is a part of the tyrosine kinase enzyme. It's a part of the tyrosine kinase receptor. So which drug could I give? The tyrosine kinase inhibitors. That's why I'm trying to introduce you to this. All right, CML, older individuals. CLL, very old individuals. Greater than 70, you're not going to see it usually until it's greater than 70. All right, so there could be idiopathic components here, but the really important thing here to remember is that it's probably an abnormality of that BTK enzyme. Could have poor prognostic indicators, meaning it does not have that variance in the heavy chain of the immunoglobulin. It means that they're kind of naive, not mature B cells. All right, that's causes. Now what I want to do is I want to say, what is the problem? What are the bad things, the complications that can arise whenever I have too many of these lymphocytes in the blood, the bone marrow, or different tissues? What's the poor outcome if I have lots of granulocytes that are mature appearing in the bone, the blood, or in the tissues? Let's do that now. All right, friends, so CML, when we talk about this one, we know now that this is a patient who has lots of mature appearing granulocytes in various different stages, right? Myelocyte, metamyelocyte, band cell, neutrophil, eosinophil, basophil, the whole thing. We know that that's usually due to increased proliferation, shutting down of apoptosis due to the 922 translocation. When these patients come in, they may get a CBC that shows a white count through the roof, enough to make you want to poop your Huggies. But sometimes they can come in with other clinical features, and it actually kind of depends upon the stage at which they're in, or the phase at which they're in within CML, that determines the severity of these clinical pictures. So sometimes it may not be a very kind of like obvious picture. It could be relatively indolent. Most patients actually live in this what's called chronic phase of CML, 80% of them. So let's talk about this. One of the biggest features that you have to watch out for with CML is splenomegaly. The concept behind this is probably twofold. Let's say here I have a normal spleen. So here's my normal spleen. And I have a patient with CML. What's the big problem with this one? They are pumping out a lot of these granulocytes at various different stages. Now, sometimes it's always important to remember that in chronic leukemias, they do produce a small percentage of blast cells. It's not a significant amount, but it's a small percentage. And it depends upon which actual phase they're in that actually determines the amount of blast cells. So they may have a little bit of blast cells, but you're gonna have a lot of these mature-ish appearing neutrophils, eosinophils, basophils. And what happens is they're gonna wanna go here and deposit into this spleen. And when it deposits into the spleen, it's going to make the spleen enlarge. So here, you're going to get this deposition. You're going to get deposition into the spleen of these blast cells and granulocytes at various different stages. And then from here, you're going to get an enlargement of the spleen. That's where you're going to get the splenomegaly, because they're going to be taking up some of that space. Now, that's one reason. Another reason is because some of these blast cells, you do have a small percentage of them, but some of the blast cells can get deposited into the spleen, right? So let's say now you get some of that deposition into the spleen as well. You get some of that deposition here. And then what happens is some of these blast cells actually start taking over and trying to actually trigger the production of all other different types of blood cells. What's that called? Hematopoiesis. But it's not occurring in the bone marrow, the red bone marrow. It's occurring outside of that. This is called extramedullary hematopoiesis. This thing will actually start to trigger the production of other blood cells. And what is this called? Extramedullary hematopoiesis. Now the problem with this is that this is definitely going to cause that spleen to get bigger and bigger and bigger. So this right here, this process here is called extramedullary hematopoiesis. That's going to start trying to make more of these cells, more of the platelets, more of the red cells, more of the white blood cells. As a response, due to not only from the deposition, but also from this extramedullary hematopoiesis, it's going to cause the spleen to get bigger, and that's going to lead to splenomegaly. Splenomegaly can sometimes be asymptomatic, but as it gets bigger and bigger and bigger, it can start causing an enlarged mass on that left flank. So obviously you want to watch out for a couple different signs. One is a palpable left upper quadrant. A palpable left upper quadrant, or pain. Sometimes they can have pain. The biggest, most common presentation here is that with splenomegaly, it's a large organ that it compresses onto the stomach, and it decreases the space within the stomach. So whenever food and fluids are supposed to come down, it stretches the stomach, which helps to initiate the satiety process. If it's smaller than usual, you're going to have satiation a lot earlier. And so they tend to have a poor appetite or early satiety. So that may be the things to consider is these patients who have early satiety, some undesirable weight loss because of that, some food aversion, these patients who have decreased appetite, those are things to consider. Now, here's what's really, really important to remember. With CML, you definitely get deposition. You definitely get extramedullary hematopoiesis. So it's either the depositing of the blast cells and the mature appearing granulocytes, or it's due to the spleen from some of those blast cells producing other blood cells and getting bigger as a result. When that happens, depending upon the phase of CML determines the severity. So for example, if a patient has chronic phase CML, this is the most common. And usually in this phase, you can actually quantify the number of blasts that they have in there. So if you actually take a look at the bone marrow and you say, how many of the actual bone marrow is made up of myeloblasts, you can determine which phase they're in. If it is less than 10%, this is called chronic phase. This one is usually very mild to moderate splenomegaly. So sometimes it's very mild to moderate. You could have very little symptoms, or you could have mild symptoms like a little bit of a palpable and large left upper quadrant, a little bit of early satiety. As you go to the next thing, as the patient acquires more mutations, because that's what happens. Every time you proliferate a cell, every time my epidermis continues to replicate, you undergo the possibility of developing more mutations. So here's some mutations arise. If mutations arise, you could potentially get more blast cells. If the blast cells increase in number from less than 10 to 19%, now I'm in the accelerated phase of CML. At this point, we're actually probably going to start seeing symptomatic splenomegaly. This is where you're going to start seeing some pretty good symptoms of splenomegaly. You're definitely going to see the enlarged and palpable left upper quadrant, some early satiety, some nausea, vomiting, decreased appetite, anorexia, weight loss. It's when we get to this last one that it's scary. So if you continue to undergo more and more mutations, and these arise and you get more proliferation, less differentiation, you can then enter into what's called the blast phase of CML. This is now whenever you have greater than or equal to 20% blast cells. These are all blasts. So remember, you have less than 10% blasts. You have 10 to 19% blasts in this phase. And if you have greater than or equal to 20% blasts in this stage, this is now at a point where you have splenomegaly that is so severe, you're at high risk. That spleen is probably big as can be, all right? Huge, gargantuous. That thing is at high risk of splenic rupture. So this is now a patient who likely has AML, because once you have greater than 20% myeloblast, what's that diagnosis? AML. You can have a patient who has high risk of splenic rupture. This is the biggest, most concerning complication is splenic rupture. So this is what I want you to remember. The severity of splenomegaly kind of depends on the phase at which they're living in. More common than most of the phases. Less than 10% blast, they get a little bit of mild to moderate splenomegaly. They get to the accelerated phase, they have more blasts, the spleen's getting bigger, they're probably getting symptoms. At this stage, they have severe splenomegaly to the point where they're at high risk of splenic rupture. And this is a patient who is now converted from CML into, via the blast crisis, into AML. And we'll talk about that a little bit here in a second. But this is the really, really important complications that you have to realize. CML, severe splenomegaly. What else can they have? They can have anemia and thrombocytopenia. And again, it kind of goes back to which phase they're in, but this is really important. It's actually super straightforward, thank goodness. This one, you have tons of different types of granulocytes. You have metamyelocytes, myelocytes, neutrophils, eosinophils, basophils. You may even have some blast cells in there as well. This basically crowds out the marrow. If you have all of these cells, they're huge. They're taking up a lot of space. If they crowd out the marrow, that means that there is less space available for other normal cells to be produced. And what that does is that leaves less space for the production of normal red cells, normal platelets, and even some white blood cells. All right? Now, if that's the case, and I don't produce now, or I don't push out of the bone marrow as much of these red cells or as much of these platelets, this is going to be the part that's inhibited. I will have less platelets and I'll have less red cells. This is where you get the diagnosis of anemia, and this is where you get the diagnosis of thrombocytopenia. So here's my anemia, and here's my thrombocytopenia. Important to remember, patient with CML, big thing they can come in with is potential early satiety, left upper quadrant pain, maybe even some like nausea, vomiting, anorexia from that. But the other thing is fatigue. Why fatigue? Because of the anemia. So they could potentially come in with fatigue or pallor, and that's really important to remember. All right, so watch out for fatigue or pallor. That could be due to the anemia. The other thing is if they have less platelets, what are platelets supposed to do? They're supposed to help us from not bleeding. We don't want to bleed, but they're important to help us with hemostasis. If we don't have them, the patient can develop bleeding or bruising. And how could that look? Well, depending upon the degree of bleeding, they could have epistaxis, they could have menorrhagia, they could even have potential gingival bleeding. Another thing that can happen is they could have skin bleeding, usually in the form of the bruising, which is the petechiae or the purpura. So those are important things to potentially consider in a patient who has thrombocytopenia. Now, if a patient comes in, splenomegaly, anemia, thrombocytopenia, you definitely want to be thinking about CML. Again, it's important to remember that the degree of anemia and thrombocytopenia depends upon the phase. So when you look at this, again, we already know the percentages. So for chronic phase, it's less than 10%. These patients usually at this stage, they have a very, very elevated white blood cell count. And they usually have anemia. Their platelet count is usually somewhat variable. Could be normal, could be low. But they're going to have a super high white count and they're going to have anemia. In the accelerated phase, which is what's the percentage of blast cells? 10 to 19. At that point, they'll still have a refractory leukocytosis. So their white count is still going to be pretty dang high. At this stage, they'll have anemia and they'll have thrombocytopenia. This is usually the stage at which you're going to start seeing the symptomatic of both of them. Again, each time I hop from this one, more mutations. From this one, more mutations. That's the reason why you jump from these different phases. If you have more mutations, you increase the risk of forming more blasts, more blasts. So now here's a mutation, here's a mutation. At this point, I go into the blast phase. When I get into the blast phase, I have so many blasts that they crowd out the bone marrow so bad, that's when I start seeing the white cell counts go down. This is when a patient can actually start to develop pancytopenia. This is when you may see pancytopenia. At this point, they run the risk of having a low white cell count, less functional neutrophils, so they can have frequent infections and fevers, anemia, fatigue and pallor, and thrombocytopenia, bruising and bleeding. That's where I want you guys to remember. And this is a point where a patient has converted from CML into AML. With that being said, we kind of discussed this a little bit throughout this process, but CML, that's the biggest risk. If you guys go back to AML, we talked about the causes behind it is usually genetic, trisomy 21, so Down syndrome increases that risk by 10 to 20-fold. APL is due to the 15-17 translocation. Could be due to chemoradiation, but what was the other thing I said? Could be due to bone marrow disorders. So bone marrow disorders includes your myeloproliferative neoplasias, things like polycythemia vera, central thrombocythemia, your primary myelofibrosis, and what's the big one? CML. CML can convert into AML. The whole concept here is pretty straightforward. Again, as we talked about before, you accrue more mutations. So you enter into the different phases. So you start off with the, let's see if you guys remember, chronic phase of CML. Then you go into the accelerated phase of CML. And then you go into the blast phase of CML. As you progress through these phases from less than 10% to 10 to 19% to greater than 20%, now at this stage, when I take a bone marrow biopsy and I look, I'm going to have greater than or equal to 20% myeloblasts with our rods. You guys remember that? right? At this point, I have AML. AML crowds out that bone marrow, right? And so that's where you get the pancytopenia. The other thing that happens here is that once you start getting lots of myeloblasts, these puppies start leaking out of the bone marrow and into the bloodstream. And you can start seeing potentially these higher levels of blasts. If I have lots and lots and lots and lots of these blasts inside of the bloodstream, the concern here is whenever again, you have to remember, and this is what sometimes gets really confusing for people, is that the blasts accompany the white count, right? So you're gonna have lots and lots and lots of these blasts. So they can actually cause your white count to go up. But your number of functional neutrophils, your neutropenia in that sense, becomes less because you're having more blasts crowding out the marrow, leading to less production of functional neutrophils. That's why it's technically, you're having a neutropenia, and that's why they're at high risk of fevers and infections. In this scenario, you can have so many blasts that the white cell count could potentially go up, greater than 100,000. If that white count exceeds 100,000, what do you run into? What were those big two complications of AML? Do you guys remember? One is if the white count exceeds 100,000, white blood cell greater than 100,000, you enter these microvascular occlusions. The viscosity goes up, you occlude the small vessels in the brain and in the pulmonary circulation. What happens? You end up with what's called leukostasis. This is the big oncologic emergencies that we can see when a CML is converted into a AML patient. The other thing is that if a patient has this and they really have heavy turnover of cells, or they get hit with some chemotherapy and these cells pop open, what can they release out? Lots of phosphate, lots of uric acid, lots of potassium, and then what will happen to the calcium because of the high phosphorus? You'll drop the calcium, right? So these patients can have high amounts of phosphate, they can have high amounts of potassium, they can have high amounts of uric acid, and again, because of that high level of phosphorus, what will it do to the calcium? It'll drop the calcium, right? So all these things are going to be spilling out of these cells, and this is usually the electrolyte abnormalities that you have. This can lead to tetany, this can lead to cardiac arrhythmias, this can lead to acute kidney injuries and gout flares. You get the point here. This is called tumor lysis syndrome. All right, this is called tumor lysis syndrome. Now remember, the most common type of leukemia which occurs with tumor lysis syndrome is which one? ALL, but you can still see it in AML, right? That's the concern here, is a patient started off with CML, maybe less than 10% blast, lots of the mature appearing granulocytes, had more mutations. As the mutations accrued, they developed accelerated phase, 10 to 19% blasts. That's a little bit less of those mature appearing cells now. Then you go into the blast phase, greater than or equal to 20% of the bone marrow is made up of blasts, myeloblasts. That's significantly less of these mature appearing granulocytes and way less functional types of appearing white granulocytes. High risk of infections. But the other thing is as these blasts escape into the bloodstream and they really build up, if they go above 100,000, you can get leukostasis. If you go up to the point where these cells start busting open from a high cell turnover, you run the risk of tumor lysis syndrome. These were the two big complications that we talked about in AML. That's what you have to watch out for. You can have a patient with CML and all of a sudden they start developing complications of AML. Why? Probably because they finally had the blast crisis. That's why you need to know this. All right, so the next component here is we're going to talk about the complications of chronic lymphocytic leukemia. With this one, it's similar. You're just hitting a couple different extra complications, just a couple extra. Now you remember, the lymphocytes love lymphatic tissue. They love the lymph nodes, so they're going to meander to that area. So whenever you have the bone marrow pumping out lots of that lymphocytosis, right? We're getting lots of lymphocytosis. These lymphocytes are going to do what? They're going to go and deposit into the lymph nodes. It's not out of this world to think that. And these suckers are mature appearing. So now, once we get to that point, when you get lots of these lymph nodes depositing here, then what can happen? All right, let's talk about this. Let's say here we deposit, and then from here, we get too many of these lymphocytes that they actually start causing some degree of enlargement of these lymph nodes. Right? So they get a little bit bigger. You get like a cluster of these lymphocytes, they start kind of actually causing stretching and enlargement of the lymph node. It's called lymphadenopathy, right? When that happens, you can have this painless swelling of lymph nodes. Now you have to remember, what's the the most common locations for this to occur? It can really occur in any kind of lymph node you can imagine, but the most common locations are going to be your cervical, right? The axillary, the supraclavicular, and the inguinal. Sometimes they can get into the mediastinum as well, so watch out for that. But definitely look in the cervical region. You're also going to want to look in the axillary region and the supraclavicular. Take a look and meander down to the inguinal region if you can to check that out. And again, watch out for that mediastinal lymph nodes. But that's really important to remember. Now here's one, I got to talk about another definition. So there's a disease that's called small lymphocytic lymphoma. Small lymphocytic lymphoma, SLL. All this is that you have a lymphocytosis, right? So it's two things. It's a lymphocytosis, except we define that lymphocytosis, which is weird. For CLL, it has to be greater than or equal to 5,000 cells within per microliter. This one, you actually want it to be less than 5,000 per microliter, all right? Which is a little bit odd, but that's one component for SLL. The second component for SLL is you also have to have the presence of lymphadenopathy. So you also have to have lymphadenopathy. So they're essentially the same kind of like disease. We just classify them a little bit differently based upon the involvement of lymph nodes. That's really it. So CLL can involve lymph nodes, but if it causes lymphadenopathy and the lymphocytosis is less than 5,000, it means that a lot more of them are probably in the lymph nodes. We call it small lymphocytic lymphoma. But that's going to be the big thing, is watching out for lymphadenopathy. What would it look like? It would look a little bit like this. Here's what we have to talk about, one more thing. Let's say that you had a patient, they have some cervical, they have some axillary lymphadenopathy, right? All of a sudden, they come back. They come back to you maybe some time later because they undergo something called a Richter transformation. You're like, a Richter transformation? What? A Richter transformation is pretty ominous. And you don't want to see this, but it is something that you have to watch out for. This lymphadenopathy gets terribly big. Now this thing is growing rapidly and it's become more diffuse and it's hitting more lymph nodes and more lymph nodes. And so now you have a kind of a classification of a non-Hodgkin's lymphoma. This is a patient who now has what's called diffuse large B-cell lymphoma. This is a high-grade, very, very aggressive type of non-Hodgkin's lymphoma. And it happened because we started off with some lymphadenopathy, some clumps of those abnormal lymphocytes, and they just start really, really getting bad and huge. Now the lymph nodes rapidly grow. All right, so how do we really differentiate between just normal lymphadenopathy and the diffuse large B-cell lymphoma related to lymphadenopathy? Well, maybe you started off with like a cervical lymph node, and then all of a sudden, that thing rapidly grew, all right? So if you have rapid enlargement, so rapid enlargement of lymph nodes. That's one sign, right? The second one, and I didn't really specify this as well, but you know whenever these lymphocytes, they deposit here, right? When they deposit into the lymph node and they kind of get this little cluster here that causes a little bit of enlargement here, these cells can also, these lymphocytes, have the capability of releasing small amounts of cytokines. Interleukin 1 is one, tumor necrotic factor alpha is one, and this can cause your fever, your chills, your night sweats to a degree, right? Because they change the hypothalamic thermostat, essentially. And so these are some of the features that could be present. We kind of like equivalent these to B symptoms to a degree, right? That can happen because of these cytokines being released in just a little bit of a larger amount because of the prominence of these lymphocytes. So if I see that their B symptoms are through the roof, they're having high fevers, chills, night sweats, that's one sign. So increasing, we're going to call these B symptoms. Increasing B symptoms. That would be concerning. The last thing is there's a cell turnover marker called LDH. Right, LDH is kind of a good sign of, or not a good sign, it's a bad sign of cells rapidly turning over. And that could be another thing that you'd want to check for, is a rapidly elevated LDH. So if a patient has rapidly enlarging lymph nodes from prior, they have more B symptoms and their LDH is up, you may have converted from a small lymphocytic lymphoma to a diffuse large B-cell lymphoma. That's really, really important to differentiate. All right, so now we're gonna move on to the next component here, which is hepatosplenomegaly. So we know that the lymphocytes love the lymph nodes, so don't forget, again, really high lymphocyte count, lymphocytosis, and then you combine in the next factor of lymphadenopathy, that's the biggest, most common presentation usually of CLL. If you get down to these further complications, we actually can remember this via the RYE system. So RYE 0 is they have isolated lymphocytosis, so a really high white cell count, and it's lymphocyte predominant, greater than 5,000 cells per microliter. If you add in lymphadenopathy, that's RYE 1. If you add in hepatosplenomegaly, that is RYE 2. So now RYE 2 is going to be a patient has a increased, again, production of these lymphocytes. And when you got all these dang lymphocytes, they love, obviously, to go to the lymph nodes, but they also can deposit to a mild degree in the liver and the spleen. Now, when these deposit here, they become enlarged. So now this patient will have hepatosplenomegaly. That hepatosplenomegaly is going to, again, do what? It may cause some degree of changes in the presentation of their palpable aspects of their liver and their spleen. So they may have a palpable spleen, usually the left upper quadrant. They may have a palpable liver, which is in the right upper quadrant. And then the symptoms is usually that these two organs are mushing on the stomach, which is what? Satiety, early satiety. Sometimes because of that satiety, they could have a decreased appetite. They could have, potentially if they eat too much, some nausea, some vomiting, some anorexia, some weight loss. So these are all potential effects that you want to watch out for with hepatosplenomegaly. You may not see these. These actually may come up on a CT scan, and it can actually just cause obviously glaring enlargement on the CT scan, which looks a little bit like this. So now that we've seen that this patient can have lymphocytosis for RYE 0, lymphocytosis plus lymphadenopathy, RYE 1, lymphocytosis plus hepatosplenomegaly, RYE 2, what's the next component? The next component is anemia. So for anemia, we're going to go into the step of RYE 3. RYE 3 is you have lymphocytosis plus the presence of anemia, and technically, to be super specific, this anemia has to have a hemoglobin threshold. So the hemoglobin has to be less than 10 to truly fit this RYE 3 criteria. Now, the mechanism behind the anemia is just a little bit of an extra add-on to what we talked about with CML. It's the same thing. You got all these dang cells here, all these lymphocytes that are just building up inside of the bone marrow. They crowd out the bone marrow. If you crowd out the marrow, which is what we've continued to use that terminology for so much, you make less space. Less space is going to be available in the bone marrow now to do what? To produce other cell lines, such as your red cells and such as your platelets. As a result here, you're going to end up with less red cells and you're going to end up with less platelets due to the crowding out effect. You got all these lymphocytes just building up here, crowds out that space. Now, if a patient comes in with anemia, that's due to the low hemoglobin, right? That's going to be defining that. If they come in with low platelets, you would have the thrombocytopenia. Now, technically, thrombocytopenia is less than 150,000, but to meet the RYE 4 classification, it has to be less than 100,000. We'll get to that. Now, anemia, we know how these patients usually present, right? What's the presentation of anemia? Do you guys remember? So anemia, less oxygen carrying capacity, the most common presentation is going to be fatigue or pallor. Sometimes it can express as dyspnea. Sometimes it can even go as far as causing angina, muscle weakness, etc. But these are going to be the biggest ones. Now, here's what's really interesting. This aspect of anemia, when you do the workup for a patient comes in with anemia, you see that they have a low hemoglobin, you check their MCV. Their MCVs for these are going to be normal. Then you have to ask, is it a bone marrow problem? Or am I destroying these things, chewing them up somehow? That's usually the question that you come to. Or am I sequestering it in the spleen? So how do you determine if you're chewing up something or if it's a bone marrow problem? You check a reticulocyte index. If this anemia is present, what would you find on their reticulocyte index? So for this one, you would actually look on their workup here. They would have a normal MCV and their reticulocyte index would be less than 2%. So you would have a normal MCV, and you would have a reticulocyte index less than 2%. That tells me that's a bone marrow problem. I would then go get a bone marrow biopsy. When I see that, I'll have a hypercellular marrow that explains it. This other mechanism is different. Some of these lymphocytes, they escape out here into the bloodstream. And what they do is they become undesirably able to produce immunoglobulins. Oh man, I'm gonna produce some IgG. immunoglobulins. These are going to go find specific antigens that are present on the red cell. And then they're going to go bind on to these antigens that are on the red cell. When they do that, they tag the red cell. And from here, this is going to go to the spleen. And when it goes to the spleen, it'll undergo hemolysis. What kind of hemolysis? I'm testing your knowledge here. Extravascular hemolysis. Now, either way, it is hemolysis. So if you did check their hemolytic labs, yes, you may see a slightly increased LDH, maybe a decreased haptoglobin, maybe you'll see some increased bilirubin, you'll have some splenomegaly that's also present. But what's the big thing that determines this? And then what is this type of anemia? This is anemia. This is called autoimmune hemolytic anemia. Autoimmune hemolytic anemia. So this extravascular hemolysis due to antibodies destroying it is called autoimmune hemolytic anemia. If I did a CBC, I'd get the hemoglobin that's low, I'd get the MCV, it'd be normal. I check a reticulocyte index. Ooh. So then if I go the extra step here and I check a MCV, MCV would be normal. Reticulocyte index would be elevated. All right, so I'd have a normal MCV. I'd have a elevated reticulocyte index, but what's the key test that I want to check for? Come on, tell me. The direct antibody test, or the Coombs test, and that would be positive. Because it's going to show me that I have autoantibodies that are attacking the red cells. So whenever you have a patient who comes in with anemia and they have a really high white count, you can say, okay, could it be to the bone marrow? Or could it be due to the autoimmune hemolytic anemia that's occurring here? How do I really tell the difference? You may have a little bit of an overlap, but in perfect world, if it's hypercellular marrow, normal MCV, retic index is low. Means that the bone marrow is not really working. In autoimmune hemolytic anemia, it tells me that the retic index would probably be high, but more importantly, I would check the direct antibody test. And if that's positive, it tells me autoantibodies are attacking my red cells. And that's contributing to this. That is the big, big telltale sign. This is something that's really, really important in CLL because again, CLL can actually cause a autoimmune hemolytic anemia. Usually it's a warm type. If you guys go back to all of those, cold and warm, the warm type is CLL. All right, with that being said, we come to the thrombocytopenia. So Rye0, lymphocytosis. Rye1, lymphadenopathy. Rye2, hepatosplenomegaly. Rye3, anemia. Rye4, thrombocytopenia. At this stage, if a patient has Rye4, they're pretty severe. So at this point, we need to know again that this is a platelet count. We oftentimes define it as less than 150 in normal cases, and this, we actually want it to be less than 100,000 to meet that Rye criteria. Same thing, you got all these lymphocytes. They are crowding out that marrow. When they crowd out the marrow, they leave less space, my friends. If you have less space here in the marrow, what's going to happen? You're not going to have enough space to produce these red cells, enough space to produce the platelets. You end up with the anemia that we talked about over here. All right, so now we have this anemia that we discussed with the fatigue and the pallor. Tell the difference between the direct antibody test. If it's positive, it's autoimmune. If it's negative, it could be due to that hypercellular marrow. Here, we're going to have less platelets. This is our thrombocytopenia. Now, in this scenario here, thrombocytopenia does what? What kind of presentation do you usually have with thrombocytopenia? You'll have bleeding and bruising, right? That's the one thing you want to watch out for here, is watch out for the patient to have presentations of bleeding or some bruising. These lymphocytes, these puppies are producing immunoglobulins. These immunoglobulins can bind onto proteins. I'll just use these as like little red proteins. This is your GP2B3A. You're like, oh my gosh, this stuff again? Yeah. They bind on here. They tag these platelets. They send these platelets to the spleen where the spleen will have the macrophages destroy the heck out of them. And now I'm going to destroy these things. This destruction of platelets, so I'm going to destroy these platelets. And then the spleen's going to get bigger. They get splenomegaly. This here is autoantibodies, which again, these can be Ig, G. These are attacking the platelets. They're tagging them to be destroyed by the spleen. When this happens, this is called ITP. All right, immune thrombocytopenic purpura. Some people say idiopathic thrombocytopenic purpura, but again, this is immunogenic. This is an immune process, thrombocytopenic purpura. What happens here is ITP is a diagnosis of exclusion. It's not something that's very easy to diagnose. In other words, if I have a patient, CLL, I check their platelet count, it's low, and I go ahead and I say, okay, in this scenario, I think it's due to the hypercellular marrow. I would go ahead and get a bone marrow biopsy. If I get the bone marrow biopsy, it shows me a hypercellular marrow, done. I can't really make the diagnosis of ITP completely. If this wasn't the case and I ruled out every single other potential cause, HIT, DIC, any kind of TTP, HUS, I ruled out all of these different things. And then I finally got to the last diagnosis of ITP. Okay, cool, I made the diagnosis, but it's not an easy one. Here's what I do want you to know. CLL, it is associated with ITP and autoimmune hemolytic anemia. And there's a term that sometimes is tested here. If a patient who has CLL presents with autoimmune hemolytic anemia and ITP, this is called Evans syndrome. So that's something I would actually want you guys to consider remembering here. So CLL can precipitate as autoimmune hemolytic anemia and ITP, which is called Evans syndrome. So this is the time where it might be a little bit more likely that you could think about ITP, a little bit less as compared to all the other causes if a patient also has associated autoimmune hemolytic anemia and a predominant diagnosis or a historical diagnosis of CLL prior to this. All right, at this point, we've talked about the biggest complications that are really, really important to know for prognosis. There's one other one though. This is not a part of the RISE system, but it does tell you that it's important to remember the true function of white blood cells to fight off infections. So patients who have CML, they're definitely at risk for infections, still at risk for infections, but CLL is a really, really big one. Think about this. In a patient who has this hyperproduction of lymphocytes, so here you're gonna have all these abnormal, and again, they're mature appearing, but they're abnormal B cells. These abnormal B cells turn into abnormal plasma cells. These abnormal plasma cells produce less functional immunoglobulins, which I'm going to call Ig immunoglobulins. Could be IgG, IgA, IgM, IgE, IgD. But this is the process here. I got these abnormal, less functional B cells turn into less functional plasma cells. They make less functional antibodies. If I have less functional antibodies, why is that a problem? Antibodies are supposed to neutralize a pathogen. They're supposed to help with opsonization, which helps with phagocytosis, complement fixation, causing direct cytotoxicity from different types of natural killer cells. If I don't have functional antibodies, I won't be able to neutralize, opsonize, fixate complements, and cause direct cytotoxicity. Because of this, because I'm not able to do these things, such as neutralize, such as opsonize, such as complement fixation, such as cell killing or cytotoxicity. Because I am not able to do these things because I don't have the functional antibodies, all this does is it allows these bacteria to grow. And if these bacteria can continue to survive because I don't have the immunoglobulins to kill them, these bacteria can start causing a lot of havoc. And they can lead to things like sinusitis due to Streptococcus pneumonia, Haemophilus influenza. They can lead to things like bronchitis, but the scariest one is pneumonia. This is the concerns that you have to have, is these patients can get recurrent infections such as this. If this happens continuously, where they at least get 2 or more of these within a 6 to 12 month period, you're just hitting with antibiotics all the time, you should probably give them immunoglobulins. That's the significance here of why I wanted to talk about this, is that if you don't have the functional immunoglobulins, you can't fight off these types of bacteria, which is which ones again? Don't forget this: Streptococcus pneumonia, Haemophilus influenza, put you at risk for sinopulmonary infections. They can become recurrent. And you have to treat those patients with immunoglobulins. All right, we talked a lot about chronic leukemias, but we have to now put all of this together. And let's hit the diagnostic approach. When a patient comes in with classic findings of chronic leukemia, you're thinking about what's happening to those cell lines, right? Enough of the white blood cells are really accumulating in the bone marrow, crowding it out, or in CLL, they're producing autoantibodies that are destroying red cells and platelets. What are some common manifestations? Well, anemia oftentimes presents with fatigue and pallor. Thrombocytopenia oftentimes presents with easy bruising and bleeding. Frequent infections and fevers could be evidence of hypogammaglobulinemia seen in what? CLL, but it also can be due to severe leukopenia, which can happen if you have a blast crisis. You convert from CML to AML. Another thing is lymphadenopathy is extremely common in CLL. It can start off with just a small kind of like painless rubbery lymphadenopathy that, if not checked, can progress to diffuse large B-cell lymphoma. What was the name of that transformation? A Richter transformation. We see very rapidly progressing lymph nodes, lots of B symptoms, and an elevated LDH. And then hepatosplenomegaly, especially the splenomegaly, is very, very intense and very heavily involved in patients who have CML. So really, really remember that. Now, if I have any of these symptoms, the first thing I should do is to say, okay, do I have an elevated white blood cell count? And what do these cells look like underneath the microscope? Because that's going to give me an idea if this is a mature appearing lymphocyte or if this is a immature, like a blast type of cell. It's really going to be helpful to give me an idea of what's the white cell count look like, what are all the other cell lines look like, and on top of that, what does the cell look like? Because that's going to really help me to differentiate this. Is this leukemia? And if it is it acute or chronic? If it is chronic, is it CLL or CML? Let me show you what I mean. Let's say that I get a CBC and I see that their white cell count is really high. They have a very high white count, greater than 100,000, anemia, thrombocytopenia. Okay, doesn't really tell me if it's chronic lymphocytic, doesn't really tell me if it's chronic myeloid leukemia. I don't really know yet. Let's look at the differential. I see basophilia and in a significant left shift. Light bulb should be going off. That screams CML. Why? Because in CML, it's a process of where you're producing lots of granulocytes at various different stages. And one of those granulocytes that it's very odd to have it be elevated is basophils. So basophilia is one in a left shift. Remember the myelocyte bulge. Lots of myelocytes, lots of metamyelocytes, lots of band cells that really suggest a CML as compared to like a leukemoid reaction. And then the blood smear. The blood smear is going to show me lots of granulocytes at various stages. So for example, if I take a look here and I say, okay, I'm trying to compare CML from leukemoid reaction. Again, my white cell count. What was it for this one? Greater than 100,000. We got that. Plus we got the basophilia on the differential. Leukemoid is usually going to be less than 50,000. They don't have this significant basophilia. I say left shift. I'm going to have a heck of a left shift for this one, the myelocyte bulge. This one, not so much, but you'll have a little bit of a bandemia primarily. And then again, lap score, this is what I could consider checking. It would be low here and it would be high here. But one more thing, look at this granulocytes at various stages. If I looked at the microscope as a pathologist, look what I see here. Dude, I see cells that look all kinds of different. Like, I mean, look at this. I got one cell here, one cell here. They look none of them look the same. And so I definitely have granulocytes at various stages. That's really a characteristic picture of what you could see in a patient exhibiting CML. All right, so I think I got CML, but the only way that I can truly confirm is if I actually evaluate the bone marrow and see if this is actually occurring inside of the bone marrow. So if I get a bone marrow biopsy, I tap into the bone marrow, that really should give me an answer. So if I do that, let's say that I find that they have some myeloblasts, but they also have, again, granulocytes at various stages. But when I look at them, I say some of those stages, less than 10% of his myeloblasts. Which phase do you guys remember was that for CML? That was chronic phase. If I said 10 to 19%, you would say accelerated phase. If I said greater or equal to 20%, you would say that's the blast phase, and they have likely progressed into what? They're in a blast crisis and they've converted to AML, right? Now, to finish this off, I often like to consider ordering bone marrow cytogenetics. The reason why is if I have the sample, I'm going to send it off to look to see if they have the 922 translocation, the Philadelphia chromosome. And the reason why that is super critical is because it determines what kind of therapy I'm going to give them. If they have the Philadelphia chromosome, I'm going to treat them with tyrosine kinase inhibitors. So I should know if that's going to be effective. So if I have a 922 translocation with a lot of that BCR-ABL fusion gene present, oh baby, this is definitely going to be one that I can treat Philadelphia positive CML with tyrosine kinase inhibitors. Really important to remember that. Now, if I get this from the CBC, and let's pretend I never had any of this information yet, same thing, they look very similar. I got an elevated white count, I got anemia, I got thrombocytopenia. I don't really know if it's, again, CLL, ALL, CML. It's really hard to tell. But here's the differential. Oh, I got greater than 5,000 lymphocytes per microliter. That's a lymphocytosis, bro. That tells me that this is definitely, almost likely, either an ALL or it's a CLL. But I got lymphocytes, right? And usually that's the key, is that these are going to be really what we would say are going to be mature appearing lymphocytes. But how could I really confirm that it's mature appearing lymphocytes and it's not blasts? I get the blood smear. And if I get the blood smear and a lot of these lymphocytes are mature appearing, but here's the kicker. sometimes what happens is these mature appearing lymphocytes, when you try to put them on the slide, they're super fragile and they can bust. And then whenever you look at them under the slide, they look like they're smudged, they're smushed. And we call these smudge cells. And so take a look at this actual image. So you can see here, I got some lymphocytes, right? But then look at these guys. You see these ones? They're all smudged up. Smudge cells are almost pathognomonic for the most part for CLL. So I have elevated white count. I got anemia and thrombocytopenia probably because of the combination of Evans syndrome, and on top of that, what else? Kind of crowding out the marrow. I got my lymphocytes that are built up. They appear mature, and on top of that, I got smudge cells. Oh, dude, this is likely CLL. How do I really confirm if it's CLL versus a normal kind of cell that I could have something else going on, or a mantle cell lymphoma, or something else weird? Peripheral flow cytometry. Come on, I'm going to test your knowledge. What was those proteins again? I want you guys to think. They all have CD19 and 20. Mantle cell had CD5, but what did this one have? CD23, right? So when I see these, oh baby, I know that I likely got CLL, because again, it's reminding you that what do they all have? All of them have CD19 and 20. Only CLL will have CD5 and CD23. Normal lymphocytes will not have that. So this is what really kind of screams that this is a patient who likely has CLL. So you don't actually have to get a bone marrow biopsy for CLL. Some people will go that route, but oftentimes you can do peripheral flow cytometry and that's good enough. Now, with CLL, it is really important to determine their RAI stage. And we do this by looking at what they have going on. So the first thing that you need to have for this patient is you have to have a lymphocytosis to have stage 0. And so I need to see that they have a lymphocytosis, which this patient has greater than 5,000 lymphocytes per microliter. All right, they're at least stage 0. From there, lymphocytosis is always the base. It's whatever else they have that determines which additional stage that they could be upgraded to. For example, if I have stage 1, this is a patient who has lymphadenopathy in addition to their lymphocytosis. So do they have lymphadenopathy? Oh, they do. That is stage 1. If it's stage 2, that means that we've upgraded to now the liver and the spleen are enlarged. That's going to be stage 2. If I then go and I have a patient who has anemia, then this is going to be stage 3. And then the last one, if the patient has thrombocytopenia, that is going to be stage 4. So this is kind of how we look at it. So at any point in time, it doesn't matter if they, for example, if a patient had a lymphocytosis and they had all of these things, they're stage 4. You just look for, again, what do they have, and that determines their stage. The reason why this is important is it guides the way that we will treat these patients that you'll see in just a second. All right, this really gives us an idea of how I want you to think about examining a patient with symptoms of potentially pancytopenia and some classic symptoms, and then going from there and saying, how do I analyze my CBC? How do I analyze my differential? How do I analyze my blood smear? And how do I determine what the findings of the bone marrow biopsy tell me? How do I know what to look for in the flow cytometry? And why do I get the testing to determine if they're Philadelphia chromosome positive or not? All right, so let's talk about the treatment now of CLL and really utilizing that modified kind of REI staging system. So observation oftentimes will be whenever they ask you on a question, how would you treat this patient with CLL? If they have really no symptoms or they're relatively stable. So they could be any stage. I'm talking like stage 0, 1, or 2, but they have no symptoms really, or they're very happy with where they are. You don't have to do anything. You can just observe the patient. You don't have to do a dang thing. It's when they start to have things like stage 1 and 2 and they are symptomatic or they are a little bit more unstable, then you probably should escalate your therapy and you should probably put them on something like a BTK inhibitor. You could also, in older patients, if they're stage 3 and 4, but they're a little bit older, you could also initiate BTK inhibitors. But oftentimes, if they're just completely asymptomatic, they're very stable, you don't do anything. If they're stage 1 and 2, they got some symptoms, they're a little bit more unstable, initiate it. If they're older, then you wait till stage 3 and 4 to initiate the BTK inhibitors. All right. Now, BTK inhibitors are actually kind of interesting, and this is called ibrutinib. And really what it does is it basically you have antigens, they bind to the B cell receptor. The B cell receptor then signals that Bruton tyrosine kinase enzyme. And then that then does what? Well, it's supposed to signal the nucleus to undergo proliferation and, prevent apoptosis. Well, what I'm going to do is I'm going to take ibrutinib and I'm going to bind it onto the Bruton tyrosine kinase, and that's going to inhibit that signal to the nucleus. And if I block the signal to the nucleus, I say, hey, stop it with the dang proliferation and allow for these cells to die. And so it actually helps in that process of kind of the CLL patient. Another thing that we can do is we can treat patients with fludarabine and cyclophosphamide and rituximab. So this is called the FCR therapy. We do this for patients who are stage 1 and 2, and they're also unstable and symptomatic. That's another potential therapy that we can go with. Or we can do this in patients who are REI stage 3 and 4, but they're very young and they're fit. We've seen a lot of the evidence in the literature suggest that BTK inhibitors are going to be more of the go-to, should be more of the first-line therapy as compared to the FCR therapy. But again, fludarabine, cyclophosphamide, rituximab, this might be where it's primarily utilized is in patients who are REI at stage 3 and 4, who are a little bit more young and fit and can tolerate this aggressive chemotherapeutic regimen. So again, ibrutinib for more of the 3 and 4 stage who are older, it's going to be tougher for them to tolerate that. Stage 3, 4, younger, fit, more medically able to tolerate this aggressive regimen, you would go with the fludarabine and the cyclophosphamide and rituximab. All right. Now, last thing for these patients with CLL is a stem cell transplant. If you can get rid of the stem cell and as it kind of progresses, it gets some type of abnormality that allows for it to not completely differentiate and proliferate into proper T cells and B cells. If you replace that, that would be the best way. But we oftentimes don't do this because these patients are a lot older or we've tried everything, we've exhausted every option. So again, a stem cell transplant is you're basically taking you're extracting blood cells from their bones, particularly the iliac crest. And then what we do is we transfuse this into the recipient. So you may be taking this from another patient who has some type of, compatibility. And so we've tested them, we've gone through HLA testing, and we found that this patient is a good match and they can donate their stem cells to this other patient who is exhibiting signs of CLL. All right. Now, CML is really one therapy that I need you guys to imprint into your brain. So for CLL, it's BTK inhibitors, ibrutinib. That's the primary one. That's for stages 1 and 2. If they're having, again, some degree of symptoms or they're a little bit more unstable. And for older patients who are stage 3 and 4. FCR, really the big thing I want you to remember is, again, it could be second line in patients who have stages 1 and 2 and they're unstable and symptomatic. But the primary way that we look at that one is FCR is utilized in 3 and 4 and younger fit patients who can tolerate that regimen. With CML, it's one therapy, and that's tyrosine kinase inhibitors. And we look for this, and this is why we do the cytogenetics. We want to know, do they have the Philadelphia chromosome? Because if they do, it doesn't matter which phase. It could be blast phase, chronic phase, accelerated phase. We're treating these bad boys with a tyrosine kinase inhibitor. The concept behind this is, you guys remember that BCR-ABL kind of like gene that gives me a BCR-ABL fusion protein? This thing binds with a substrate and utilizes ATP. And then again, this allows for it to send signals down to the nucleus that allows for it to do what? To precipitate cell proliferation and to shut down apoptosis. All you do when you give a tyrosine kinase inhibitor is you basically block the ATP from being able to bind. And that doesn't allow for it to activate that tyrosine kinase receptor, which is the substrate. And so then you don't allow for those signals to get sent down to the nucleus. And so that shuts down cell proliferation, and that basically kind of initiates apoptosis. And so you're basically trying to kind of rid the patient of the CML ridden cells. And so that's the concept behind tyrosine kinase inhibitors, is you're trying to inhibit that BCR-ABL activity at the tyrosine kinase receptor. And so this is going to be the primary way that we would go in patients who have CML and they're Philadelphia chromosome positive CML. Now, another thing is that bone marrow transplants or stem cell transplants are also viable options for patients who have CML. We usually do this when they're at the blast phase. And so in other words, they have greater than or equal to 20% of those myeloblasts that are in the bone marrow. It's really crowding out the bone marrow. It's causing pancytopenia. They're getting severe splenomegaly. They're getting oncologic emergencies. At that point, we'll hit them with a tyrosine kinase inhibitor. And then after that, we'll also do some chemotherapy to really lower that burden and then try from there to do a stem cell transplant. So again, CML, we would do tyrosine kinase inhibitors. That is the primary therapy. But if we need to, for a patient who exhibits the blast phase, we can do a stem cell transplant. We have to hit them with the tyrosine kinase inhibitor, try to really shut down that BCR-ABL activity, and then hit them with some chemotherapy prior to us initiating the stem cell transplant. All right. my friends, that is chronic leukemias. I really, truly hope it made sense. I hope that you guys enjoyed this and liked it. And if you really did, please continue to support us by hitting that like button, comment down in the comment section. And dude, I just love you guys. You guys are awesome. Thank you so much. And as always, until next time.